Yes, and here is your question. Right, so if you have read and understood, considering this critical care scenario, kindly tell me, how would you manage this patient now?
I will manage this patient according to the care of critically ill surgical patients
Good,
protocol.
yes.
I will firstly ensure that his airway is patent, and then I will assess and manage his breathing. I will count his respiratory rate and oxygen saturation, and then I will provide him high flow oxygen via non-rebreathable mask.
Yes.
I will assess his circulation by clinical parameters like blood pressure, urine output, pulse rate, JVP, and capillary refill, and his Gassel-Coma scale. And then I will pass 2 large bore IV cannulae and start fluid resuscitation with intravenous colloids that can be crystalloids that can be ring lactate or Hartmann's.
Yes.
And I will insert an indwelling catheter and monitor the urine output, maintaining a minimum urine output of 0.5 to 1 ml per kilogram per hour. And I will inform my consultant, the ITU registrar as well. I will send bloods for a full blood count, urea, creatinine, electrolytes, liver function tests. ABGs have already been done. So I will also send bloods for lactate levels and PT-INR as well. And after that, I will assess his wound
Yes.
and I will check his wound. And after that, I'm going to check his charts and the vitals of the patient as well.
All right, considering the ABGs that you can see on your screen, what measures would you take?
Ma'am, this is metabolic acidosis, so I will provide sodium bicarbonate infusion to the patient in a dose of 50 mLs, 50 millimoles per liter. And this will be bolus dose. And after this, I'm going to give 1.2 to 1.4% continuous infusion at a rate of 100 mLs per hour.
Okay. For how long?
This will be, I will check the ABGs repeatedly till the pH is in the normal range.
Okay. Can you please tell me what are your possible diagnoses, or what are your suspicions? What do you think might be the cause behind this condition of the patient?
A patient has undergone low anterior resection, so it can be because of sepsis or peritonitis due to anastomotic leakage.
Okay. Just suppose you send the blood out and the report comes back that the patient has raised creatinine and raised potassium level. What measures would you take then?
I would consider that the patient is having acute kidney injury, so I would resuscitate the patient. And since the potassium levels are also high, so I would start cardiac monitoring of the patient. And to lower down the potassium levels, firstly, I will give the patient 10% of 10 ml calcium gluconate intravenously over 10 minutes. And then in order to reduce the potassium levels, I will give him 5 to 10 units of insulin in 50% dextrose over 20 to 30 minutes.
What might be the cause of hyperkalemia in this patient?
It can be because of acute kidney injury.
Okay.
And sepsis as well.
Okay. Any other cause? Patient is post-op, and then? Okay. It might be the reason for persistent fever and tachycardia in this patient. What possible complication would you think of?
Due to fever and tachycardia?
Yes. What would
there
be
could be increased risk of myocardial infarction.
Okay. And it's a post-op patient, and you are, what are the differential diagnoses that you'll consider? This is what I
For
want
this
you to.
patient, I would consider anastomotic leakage leading to peritonitis or sepsis,
Okay.
and I will also consider acute kidney injury, hypovolemic shock due to the loss of blood.
Yes. Right. How would you take care of the nutrition of this patient in this particular condition?
For nutrition of the patient, I would involve the nutritionist or nutritionist so that they can calculate the nutritional needs of the patient or the caloric requirements of the patient before that the patient required before the procedure. That is the nutritional requirements of the patient in the pre-morbid status, also the current nutritional requirement rates and how much nutritional losses the patient is having. So since it is a post-op patient, so he would be requiring about 35 to 40 kilocalories per kilogram per day.
Okay, can you tell me what you understand by the term SIS?
By the term, sorry, ma'am?
SIS, S-I-R-S.
Okay, it is systemic inflammatory response syndrome, and it is characterized by when 2 out of the following 4 are positive, it is considered that there is SIRS. Either temperature is less than 36 degrees or more than 38 degrees Celsius, or total leukocyte count is less than 4,000 or more than 12,000. Respiratory rate is more than 20 breaths per minute, and the pulse rate is more than 90.
How many of these
90
factors
per minute.
can you see or can you observe to be positive in this patient?
Fever and tachycardia.
Yes, 2 of those. Okay,
Yes.
good. Right. In a post-op patient, what is the most common organism which causes infection or is responsible for infection?
Ma'am, Staph aureus.
Okay, Staph epidermis, because this is gut lower and here infection has been done. So
Okay.
yeah, all right. Okay, can you tell me what are the measures that you can take in order to prevent infection in a post-op patient?
Maintaining aseptic conditions in the
Right.
ward, and also giving the patient antibiotics according to the trust protocol and after discussion with the microbiologist. And if the patient has had culture and sensitivity, then giving him antibiotics according to that. And better coverage like broad spectrum coverage for all gram positive, gram negatives, and anaerobes need to be done.
Okay. What are the sterile protocols that can be followed?
Sterile protocols include wearing sterile gloves, sterile
Yes.
caps, sterile mask, sterile gown, and also safe disposal of the linens that has been contaminated by the patient, or safe disposal of the waste that has been contaminated by the patient.
Okay, and one more thing, because since this is a immediate post-op patient, so there are many linings which are inserted, so there should be
They should be
precaution.
checked. Yes.
Yes.
Yeah.
Right. Yes. Right. This is, yes, since you'll be managed, did you tell me what nutritional precautions would you take care of or
Yes,
would you
ma'am. In this
consider for this
patient,
patient? Yes.
yes, ma'am. In this patient, we have 2 options: enteral and parenteral. If the patient can tolerate enteral feeding, then that would be better. Otherwise, the patient would be started on total parenteral nutrition.
Yes. Okay. How long can you continue with the total parental nutrition?
Ma'am, total parenteral nutrition, it would be till the patient comes back to his oral feeding or
Yes.
enteral
Very
nutrition.
good. Very good. Okay. Yes. That was good. Thank you.
Thank you, ma'am.
Thank you. Yes. Starting your timer, and here is your question. Right. So if you have read and understood, considering the clinical examination station, kindly begin.
I will enter the room, wash my hands, get the patient. Hello, how are you today?
Yes.
I'm Dr. Muhammad, one of the surgical doctors. I have been asked to examine your ear. This will
Okay.
include looking and also using one device called otoscopy.
Okay.
Are you okay with that?
Yes.
Okay. Do you have any pain before we start?
Yes.
In which ear?
I can't tell. Maybe in both ears.
Okay. Can I confirm your name and age, please?
Yes. I'm Sarah, 23 years old.
Okay, nice to meet you, sir. Did you notice any change in your ear recently?
Yes.
Okay, so I'm going to just whispering behind your ear. Okay, I'm going to just close one of your ear and then whispering 69, 70. So do you hear that? Can you repeat it for me?
I can hear, but I can't tell what you said. There's too much noise.
Okay, okay. I will repeat this on the other side. Okay.
Okay.
Now I'm going to inspect around your ear and behind it and in front of it, looking for any ear discharge and looking for any ear piercing or any wax. And now I'm going to use this tuning fork. Okay.
Okay.
I will put it behind your ear. Okay. Do you hear this? I will just making the tuning fork tuning. I will put it. Tell me when to stop. Okay.
Okay.
Stop. Okay. Now I'm going to put it just in front of your ear. Do you hear this now? Hello.
Yes.
It is louder in your when I put it in your phone or in the air.
Sorry, doctor. I can't tell.
Okay, no problem. Then I will repeat it on the other side. Now I'm going to do the waiver test. Now I'm going to put this tuning fork in the middle of your head. Okay. Please tell me if in the mid you hear it in the middle or one of the both of ear or it's equally. Okay.
Okay.
Okay. It's is it more in your right or left or it's equally?
Still can't tell.
It's okay. Now I'm going to just assess your balance. Can you stand up for me, please?
Okay.
And now can you just march on the spot and close your eyes? I'll try to support you. Okay.
Yes.
Now can you sit down again, please?
Yes.
I'm going to just test can you just raise your eyebrow, please?
Okay.
Now can you close your eyes and don't let me open it?
Okay.
Okay, now can you just blow your cheek?
Yes.
Can you smile for me, please?
Yes.
Fantastic. Now can you tense your neck muscle like this?
Okay.
Okay, brilliant. Now, do you have any test change?
Any taste change?
Any change in your test?
Yeah. Can't appreciate anything. Yes.
Okay, it's okay. Now I'm going to just feel sensation. I'm going to put this cotton. Do you feel this? I will put it on the chest of the patient and just if you feel this, try to close your eyes and tell me when you feel it. Okay.
Yes.
We put it in the frontal on both sides and the maxillary on both sides and then in the middle. Does you feel this equally?
Yes.
Okay. Now I'm going to use this device, it's called scope. I will introduce. Do you have any ear discomfort?
Yes. I'm feeling
Okay, I will
pain.
just introduce it gently. Okay, I will put the speculum and just turn it on. I'm going to pull your ear upward and backward. Okay.
Okay. Upward and
backward.
backward. Yes.
Yes.
Okay.
Now I'm going to just gently looking for wax, tympanic membrane, any perforation, and signs of inflammation, tympanosclerosis, and just I will remove it gently, and we'll do it for the other side. Now I've completed my examination. Thank you so much for your time. Wash my hands.
Okay. Are you sure you haven't missed anything?
Facial and the vestibular.
9. Gag reflex.
Sorry.
9 and 10.
They just say that you have to
Okay,
do
just the ear examination.
yeah.
Sorry.
Yeah.
Yes.
Mainly the facial nerve and the vestibular.
Abducent, yes. Oh, right, okay. And vestibular, okay. Yes, now bell went. Okay, can you please summarize your examination
Okay,
now?
they have been examined Miss Sarah, 32 years old. This patient is having the Rhine test is negative, and also Waiver test will be just here. It's better on the right side, so this it's just unilateral conductive hair loss. And on assessing the facial nerve, it was normal. And so my main differential diagnosis could be due to Pneumatonephana,
Yes.
and also could be due to autosclerosis.
Can you please give me the differential diagnosis of Pneumatonephana?
Yeah, it could be due to nasal packing, could be due to bleeding disorder,
Yes.
and also could be due to result of trauma with a skull fracture.
All right. Can you please tell me how would you differentiate which side of tympanic membrane was
Yeah,
right or the left? Pneumatonephana there
I
is.
will look at the handle of the malleus. It will be from the top of the right to the left, and then I will see the cone of the light at the 4 o'clock. This means this is the right ear. The left ear should be the.
If you look at this image, would you be able to help me out? Pneumatonephana, if it's present, it's on which side?
Yeah, it's the corner of the light, and this is the left ear.
Okay, can you tell me what or how do you plan to manage this patient now?
As this patient might be suspected with risk fracture, I will manage the ATLS, ABCD approach, ensuring that the patient is stable, and then do some blood test routine investigations, CBC, electrolyte bleeding profile, and then do some imaging, CT for the CT head, and audiogram, and would like to involve the ENT surgeon and the neurosurgeon.
Good, thank you.
Thank you.
And here is your question. Right, so if you're read and understood considering the clinical examination statement, can you please tell me what are you looking at?
This is the base of the skull.
Yes. How would you divide the base of the skull?
I will do the according to anterior cranial fossa, medial cranial fossa, and the posterior cranial fossa. The anterior cranial fossa is anteriorly there is crista galli, and the posteriorly it is bounded by the wing of the sphenoid. And the medial cranial fossa is anteriorly is the laser wing of the sphenoid, anterocranial fossa, anterocranial fossa, fosses, and the diaphragmatic sella. And posteriorly, it is bounded by the petrous part of the temporal bone, as well as the posterior cranial process. And laterally is the squamous part of the temporal bone, and which is looking like a bat wing.
Yes.
And the posterior cranial fossa is bounded anteriorly by the apex of the petrous part of the temporal bone and the diaphragmatic sella, and posteriorly it is the occipital bone, and laterally is the squamous and mustard part of the temporal bone.
Okay. Can you please tell me if we come back to this part? You said it's the posterior cranial fossa. Can you please identify what is number 30, please?
It is the jugular foramen.
Okay. What else passes through it?
Jugular foramen is passes sigmoid sinus, internal jugular vein, as well as glossopharyngeal vagus and spinal root of the accessory nerve.
Okay, and if you can identify number 11.
Is the foramen magnum.
Can you name all the structures which pass through foramen magnum?
It passes vessels, anterior spinal artery, posterior spinal artery, vertebral artery, and medulla oblongata, and cranial root of the accessory nerve. And tentorium cerebelli and the apical part of the dens.
Yes. Okay. If you can identify number 27.
Is the hypoglossal canal.
Okay. What else? What passes through it?
Hypoglossal nerve.
Okay. Right. You told me about the fossa boundaries. Can you identify fossa lacerum?
Foramen lacerum, ma'am, it is number 10.
Okay. Can you tell me what passes through it?
Easily is covered by the fibrous septum, and superiorly it passes the internal carotid artery and petrosal nerve, superior inferior petrosal nerve.
All right. Can you identify 42 over here?
Is the superior orbital fissure.
Okay, and 44. Yeah.
Ma'am, 44 is the carotid. 44 is the trigeminal ganglion stays here.
Okay, 8, please. 8 is here.
It is the diaphragmatic sella.
34. Okay.
It is the optic canal.
1, please. There is 1.
One is the anterior clinoid process.
32.
And 32 is the border of the apex of the petrous part of the temporal bone.
13, please.
And it's the foramen rotundum.
12 below it, please.
Now ovally.
14, please.
It's foramen spinosum.
37, please.
37 is the okay. 37 is the it is the border of the apex of the petrous part of the temporal bone.
Petrous part. Okay. Yes. Can you please tell me what is pterion?
So pterion is a unit which consists of 4 bones: frontal, parietal, temporal, as well as with the wing of the sphenoid bone, whereas the medial meningeal artery stays.
What is the
the
clinical significance of it?
So the clinical significance, as behind these, the meningeal branch of the meningeal artery stays here. So if there is head injury occurs, it causes extradural hematoma.
Okay. Yes. All right. What is the carotid canal? What are the contents of the carotid canal?
So within the canal there is internal carotid artery, and sympathetic plexus around it, deep petrosal nerve and emissary vein. And in the lateral wall, there stays oculomotor trochlear and trigeminal.
All right. Okay. Can you please tell me what is cavernous sinus?
So it is a long venous sinus which passes on both sides of the pituitary fossa.
All right. One associated question with that is what is cavernous sinus thrombosis?
So cavernous sinus thrombosis, which occurs due to occlusion or third, fourth, and sixth cranial nerve palsy, which is characterized by papilledema, oculomotor pain, and headache.
What are the signs that you as a physician would appreciate if there is cavernous sinus thrombosis?
So there will be swelling of the eye, and third, fourth, fifth, sixth cranial nerve palsy, and gradual loss of vision.
Okay, good. Right. Can you please tell me if there is a metastasis of tumor or something on the skull? How would it appear?
Osteolytic lesion. It will appear as osteolytic lesion.
What is the most common tumors which metastasize to skull? Yeah.
It's multiple myeloma.
Okay, can you please tell me what are the attachments on styloid process?
Stellar process as stylomandibular ligament, stylopharyngeus muscles, stylohyoid muscles.
How many ligaments and how many muscles?
I remember 2 ligaments, 2 muscles.
Yes,
ma'am.
yes. Can you rename them, please? Styloglossus and
Styloglossus, stylopharyngeus,
yes, and
stylohyoid,
and
stylomandibular ligament.
good. Okay, right. I will go soon. Good. 5 seconds. Yeah, right. Thank you. Good. Started your timer, and here is your question. Right. So if you have read and understood, considering this surgical pathology station, kindly tell me after you have read the STEM, what are the differential diagnoses that you'll consider?
My differentials are basal cell carcinoma, squamous cell carcinoma, tuberculosis, maybe some kind of lymphoma, and seborrheic keratitis.
All right. Right. Okay. You said basal cell carcinoma or just squamous cell carcinoma. Why? What are the differences between these two carcinomas?
Right. Basal cell carcinoma is basal cell carcinoma arises from the basement membrane, while the squamous cell carcinoma arises from the usually from the superficial layers. Basal cell carcinoma has rolled in margins, while squamous cell carcinoma has usually burst out lesions. Basal cell carcinoma is usually limited, while squamous cell carcinoma is can metastasize. And basal cell carcinoma has usually pearly papule and central ulcer with rolled in edges, while squamous cell carcinoma is usually papule, which can usually bleed easily.
Okay, considering the mode of spread of the carcinoma, how do they both spread? Or how do they both?
Basal cell carcinoma is usually limited and does not metastasize, while squamous cell carcinoma spreads via lymphovascular route.
Considering the process of metastasis, there are certain series of steps which take place. Can you explain those to me, please? Or can you narrate them?
Usually, squamous cell, the cells of the tumor, they produce some vascular endothelial growth factors, which induce the which induce the production of lymph vessels in the tumor cells as well as in the central lymph nodes, and that is how this tumor cell spreads via the lymphovascular route.
Yes, but I want you to explain the process, like how the invasion takes place, how this invasion becomes infiltration, and then how the release of neoplastic cells takes place. What is the survival in the circulation? How proceeds, like whole.
Sorry.
Okay,
I
right, right. How would you, what are the tests that you'll ask for to confirm your diagnosis?
Lymph node FNAC and then biopsy.
Okay, while taking biopsy, what are the factors that you'll consider or you'll focus more on?
I will focus on the size of the lesion, depth of invasion, and also the depth of invasion as well as the vesicular thickness and ulceration if present or not, lymphovascular invasion, and mitosis present or not.
Mitosis you won't see. Margins. Okay.
Yes, margins.
Yes, all right. Okay. What measures would you take in order to prevent or in order to make sure that carcinoma does not spread?
Okay, I will make sure that the excision is complete and edges are free.
Okay, good.
Edges are free of any metastasis. And second,
kindly tell how what are the margins that you'll consider? How much excision would you? Yes.
It depends upon the vesicular. It depends upon the vesicular thickness. If it is less than 0.5 mm, then the margin should be 0.5 centimeter. If it is 0.5 to 1 mm, then 1 centimeter. If 1 to 2 mm, then 2 centimeter. If it is 2 to 3, then it should be 3 centimeter. If it is more than 4, then should be 3 centimeter.
How would it matter, or why should it matter if it's basal cell carcinoma or squamous cell carcinoma while you're excising the lesion?
In basal cell carcinoma, sorry, ma'am, repeat question.
Yes. Why should it matter when you're excising the lesion that if it's basal cell carcinoma or the squamous cell carcinoma?
Because there are the chances of distant spread.
Yes,
if
when
they
it's
metastasis. If the excision is not complete, there are chances of recurrence as well as metastasis.
All right. Okay. Which is more important to consider, breast flow thickness or clot's level when you are excising the lesion?
Base flow thickness is more important.
Okay. What does clot's level signifies?
Clark's level signifies the depth of invasion from the upper margin of the lesion till the from the upper margin of the lesion till the complete depth of the invasion.
Very good. Okay. This Clark's lesion, Clark's level is important in what kind of lesions?
In malignant melanoma.
All right, good. Okay. Right. You have taken the biopsy. What is your next step? What would you do next?
What would you?
What would you do next? What is more important when the report comes back?
I will see if the margins are clear of any tumor or not.
Yes, what is important when the report comes back?
The important thing is that if the margins are clear, then it means I don't need re-excision of the lesion. But if the margins are involved, then I need re-excision of the lesion.
Okay. How would you manage or plan the further management of the patient after biopsy report has come to you?
Of biopsy outcome, I will see if the margins are involved, margins are free of lesion, then
This is repetition. Yes, next. If it's basal cell carcinoma, like your first provisional diagnosis
Yes.
was, okay, if you can tell me what are the management steps that you'll plan?
I will take biopsy, then I will see the biopsy.
Biopsy you've already done. You've got the report. Now, what is the next step? You plan
I will
for
go for
surgical excision.
surgical excision,
What else can be
radiotherapy,
done? Yes.
radiotherapy, and
Yes.
also topical. There are some topicals like topical 5-fluorouracil and topical 5% imiquimod.
In case of basal cell carcinoma, what is more important after surgical excision you've taken place? What is more important? Radiotherapy or the cryotherapy?
Radiotherapy.
Okay,
Yes,
good. Can you please help me and explain what you're looking at?
Yes, this is a papular lesion with the central ulceration and central ulceration.
Yes, please.
Should I name the?
You have
Should
to
I just
describe the lesion? Okay. So
yes.
what are these redness around the
These are
lesion that you could see? Yes.
telangiectasia.
Okay.
And
what does this signify?
This signifies there are some epidermal dilated blood vessels
Yes.
around the lesion.
Can you see any inflammation? So you have to explain everything that you can see. If you can see inflammation or not, if there is any crust or any, whatever you see, you have to explain.
Yes.
How big is the lesion? Yes.
This is a papular lesion of the size of about 2 into 2 centimeter.
Yes.
And there is surrounding telangiectasia, and also there is ulceration on the right side, and some signs of inflammation and granulation are also present.
Okay. Size and then shape.
Yes, ma'am.
Circular,
rounded
oval.
shape.
Right.
Yes,
good.
ma'am. Oval
Yeah.
shape.
Raised. Clearly raised. Head. Yeah.
Raised.
Good.
Raised. Yes.
Yeah. Very good.
Raised.
Okay. Right. Good. Thank you.
Thank you, ma'am.
Yeah. And here is your question. Yes. 1 minute to read the question, please. All right. So if you have read and understood, considering it history taking station, kindly begin.
Okay, hi, my name is Dr. Mudassir Bashir. I am one of the exam candidates. May I confirm your name and age, please?
Yes, I'm Smith. I'm 47 years.
Okay, Mr. Smath, it's nice to see you. Today I have been asked to ask few questions regarding your condition. Would that be okay?
Yes,
Okay, how can I help you today?
I have a difficulty in swallowing. It's really troubling me. It's been
Okay,
started like 6
can
months ago.
okay. Start then you. Okay, so now I will. I am very sorry to hear this. Now I will ask some questions to reach your diagnosis. Okay. Uh, this difficulty in your swallowing, it started suddenly or it started gradually?
Started gradually, but now those days becoming more obvious. It's really troubling.
Okay. So this difficulty in your swallowing, it is more to solids or liquids or both?
I actually started with the solid first, but it's now become to the liquid as well.
Okay. So is there anything which makes this swelling difficulty exaggerate, increase?
No, no,
Is there anything which makes it relax, makes it better?
no,
Okay. Do you have any pain while swallowing?
just I have mild discomfort.
Okay. So do you have any, you feel any food stuck to your throat, back of your throat?
No,
Do any notice bad smelling breath recently?
no, no,
Okay. Do you feel acid taste at the back of your mouth, back of your
no,
throat?
no,
Okay.
no,
Any epigastric pain or heartburn, anything?
no,
Do you feel any neck swelling?
no, doctor.
No neck swelling. Okay. Sorry. So do you feel any, have you ever vomited blood?
Yes,
Uh,
just like
it
twice.
was twice during last time. How many days before? And it is recently or since 6 months? When?
Yeah, it was last time was only 2 weeks ago.
Okay.
Yeah,
So okay, 2 weeks before. So it was bright red in color.
yeah, but yes, but it was like small in amount.
Small in amount. Do you have any change in your appetite?
Yeah, don't eat like I used to. Just eat
Uh,
only little in amount.
do you have any unintentional weight loss?
Yeah, actually, I have lost a lot of weight in the last 6 months.
Mhm. Okay. Do you have any other medical condition for which you have been seeing your GP?
No, no, nothing.
Okay. Do you use any medications
Just use some painkillers for my knee pain.
for knee pain? What is the name and dose?
It's diclofenac 25 milligram.
Okay. Do you have any operation previously?
Yeah, for my knee, I have underwent knee surgery before.
Okay. So do you are you allergic to any medicines?
No,
Okay. Anyone in your family who has the same problem?
no, no.
Okay. Would you mind if I ask some personal questions?
Yes, please.
What is your occupation?
I am a hairdresser.
Okay. Who is at home with you?
It's my family, children, wife.
Okay, you can manage stairs, you can manage independently.
Yeah.
Okay, are you do you smoke?
Smoke, yeah, smoke a lot, like
How
5
many
packs per
cigarettes?
day over the last 20 years.
Do you drink alcohol?
Yeah, actually, I'm drinking like
How
3
many
units per day over the last 20 years.
how many units?
3 units.
Okay, before I go any further, I will ask, what do you think the cause of your problem?
Actually, I have no idea. Could you tell me?
Okay, we will tell you completing history and doing examination. What you are most concerned about?
Hello?
What you are most concerned about?
Your voice disappeared.
Hello, hello, hello. I can hear you.
Yes, and we can
I
hear
can't
you
hear you.
from long far away. I think your
am what?
mic, yeah, now, okay,
Now it's okay.
yeah. All right,
Okay,
Delvez,
so
can you
what
please,
you are most concerned about?
Concerned that might be cancer, something like that.
Okay.
okay.
What do you expect us from to
Can
do?
you please summarize your history taking now?
Okay, I have seen Mr. I have Mr. ABC with 37 years male who has came to us with the difficulty in swallowing since last 7 months. It has increased since 2 months. Initially, it was to the solids, and now it is both to the solids and liquids. It is gradual. It was gradual in onset, and it is now increasing day by day. The patient has one episode of hematemesis with small amount of blood. There's no history. There's history of loss of appetite, and there's unintentional weight loss. There's no manifestations of any neck swelling. No manifestations of gastroesophageal reflux disease or pharyngeal pouch. The patient he has been using NSAIDs after his knee surgery because of osteoarthritis, and he is a smoker and alcohol drinker.
Okay. Considering,
So my
yes,
main
your
differential
history taking,
diagnosis
yes,
in this
yes.
patient is esophageal carcinoma.
Okay, what other differential diagnosis would you consider?
My other differential diagnoses are motility disorders like gastroesophageal reflux disease, ecclesia cardia. Others,
Okay.
any
What-
neck swelling like
Yes,
pharyngeal pouch
what
or goiter.
investigations would you ask for to confirm your diagnosis?
Sorry?
What investigations would you ask for to confirm your diagnosis?
I will first do I will do the labs, and I will do first my complete clinical examination, and then I will go for labs and imaging. I will do imaging in the form of barium swallow. On the barium swallow, this is the esophageal carcinoma. Then features of esophageal cancer, I will go for endoscopy and biopsy. And if it is a feature of gastroesophageal reflux disease or ecclesia, I will go for esophageal manometry.
What are the treatment options that you can offer to the patient?
I will discuss this patient in multidisciplinary team
Good.
meeting, and
Yes.
I will see if the case is operable or non-operable. If the case is operable, I will go for esophagectomy with the chemoradiotherapy.
Yes.
And if the case is not operable, we will go for palliative therapy in the form of stenting, gastrojejunostomy, or palliative chemoradiotherapy.
All right, good. Thank you. 5 seconds left.
Hello?
Yes, there's problem with your mic, that's why we sometimes cannot hear you.
Maybe.
Yes, so the feedback that we have to give you, it was good, but there are some points that we want you to practice more on. that is, if we begin from the beginning, Dr. Mohammed, would you give feedback or should I?
Yes, I think he did great.
Yes.
He reached the diagnosis and everything,
Yes.
but you just have to ask more faster because of the time.
Because of time.
Because you stop at the eyes. This is important part of the history, idea, concern, expectation.
Yeah.
So just try to ask faster, and if you may ask 1 to 2 questions. You did ask me about if there is any a pain in my epigastric area. I think that's medical term.
Medical term.
Just say tummy.
Yeah.
Yes. So in the differential diagnosis, you missed. You didn't ask about neurological myasthenia gravis and neurological cause such as weakness in my arm, legs, and painful cold hands. It could be due to myasthenia gravis and so on. Upper motor neuron lesion. But I think overall he did great.
Yeah, neuro and autoimmune causes he didn't rule out.
Yeah.
Yeah, good. Okay. Yes, one of the points that I wanted to also mention is the same, that try not to use medical terminologies, and you have to be as layman as you could. Secondly, once you did say, yes, I'm really sorry to hear about your condition, but then you have to make sure that if you're saying it, you should mean it as well. Did you ask about the gurgling sound or the wet voice after swallowing?
I asked about something food stuck in your throat and bad smelling breath.
Yeah,
But,
there is lump, feeling of a lump in your throat. But then gurgling noise, notice the gurgling or the wet voice that you forgot to ask. When you asked about the hematemesis, you can, because the patient said blood was little, then you could have asked how little was it, how less was it a teaspoon or was it just a streak? Because even a streak is little, a teaspoon or half a teaspoon, that is also little. Another question that your question was it a fresh? No, blood was fresh, but then you asked in a question, in a asking manner. Instead, you can maybe rephrase it and ask, what was the color of the blood? Right? Was it a fresh blood? Like if you rephrase your sentence, it would make more sense, right? And then like Dr. Muhammad said, you just the neuro and autoimmune causes. You forgot to ask if you suffered from any painful cold hands or if there are any dryness of the eyes or the mouth. You did ask if patient can manage stairs himself. Yeah, that was also one of the, that you can also ask like this. Did you ask about the bowel changes? Any? Yeah, this you didn't ask. So this you could have added as well, that if you have noticed any change in your bowel habits, do you open the bowel every day? Is it the same as always, or have you noticed any change in it? So yeah, if was it darker or the usual, if there was any smell change. So this simply questions quickly could have asked. Right. Yeah, that's about it. And then at the end, when I asked you to present your history, I wanted you to tell me what part, because of the history taking, was left. So always begin that if time would have allowed me, I would have asked this, because you asked your expectations, idea and concern. You asked about the idea, but then the concern and expectation was left. So that, thank you. Anyone else want to?
Ma'am, I have two questions.
Yes, please.
You see, I had in my mind that I could ask something about like autoimmune disease and neurological disorders, and also about pharyngeal pouch, another more questions. But you see, if
Time.
during the history taking,
Yes,
If you think that you are getting out of time,
yes.
so can we skip some differential diagnosis questions or some about one differential diagnosis? We can, instead of asking 4 questions, we ask 2 questions and go further.
Right, this is a very tricky question. If at the end of the exam history taking, you by mistake mention that what are the other differential diagnoses that you consider, and you mention that differential diagnosis question that you did not ask in history taking, this will give a very negative impact. So always be careful and always prepare your history taking very well. So like if it's dysphagia, if you practice this dysphagia 30 times, 30 on a patient, and you know that it's okay, what would be the history and what are the questions that you have to ask, which will be covered within the 6 minutes. And then you focus on only those differential diagnoses that you ask during the history taking, and only those you mention at the end. So it's all right, it's a safe game. But if you
So
mention
instead of
something,
asking 4 questions, we can ask 2 questions enough for the differential if you have start of time.
yes, so first you have put the cancer, and the second you have to rule out GERD, or if there was any, so if to rule out any autoimmune disease or myasthenia gravis or anything, if you have not asked any question to rule that out, you cannot mention in your differential diagnosis myasthenia gravis as your differential diagnosis. This is just simply I'm trying to explain.
So,
So-
I completed my history in 5 minutes.
In 6 minutes. Yeah, you took 6 minutes today, and then after when I was asking you to present your history taking, then I gave you 1 minute extra because there was disturbance with your mic and because of technical issues. I gave you 1 minute extra. In exam also you will be given or you can be given little time extra because it's 10 minutes, altogether. So
So if you give me marks out of 20, how much marks I will get?
out of 20, yeah, I won't fail you because your diagnosis was correct, your investigation and management was also correct, but then there was still room for improvement. I'll give you like 14, 15, like halfway. Yeah, still according to me, like there was still little room for, like, you could have done more better. Right, thank you.